Alrighty, everybody. Thank you so much for joining us on the next episode of the APV Podcast. I'm Kiara, your host, and today we have Dr. Marcela Frazier with us. I'm going to go ahead and turn it over to Dr. Frazier to allow her to introduce herself and tell us a little bit more about her.
Hello, it's so good to be here. Thank you for having me. I'm Marcela Frazier, actually Marcela Herrera Frazier, because I'm originally from Colombia. And when I was a little girl, I had a lot of vision problems. So this is very near and dear to my heart. I came to the United States when I was 18 and then went to the University of Central Florida for undergrad, then to optometry school at the University of Alabama in Birmingham. I also did a residency in pediatric optometry there and a master's in public health. And I've been at the University of Alabama at Birmingham for 20 years on faculty. And so my day-to-day is, for a lot of the beginnings of my career, I did a lot of teaching and research in the pediatric eye disease investigator group. I currently do mostly clinical working. I end up seeing about 25 children a day. And amblyopia is one of the main reasons that I'm here.
Well, we are so happy to have you and to touch on this topic. So today we are going to be talking more in depth about amblyopia. If you've listened to our previous podcasts, we have touched slightly on amblyopia, but today we are going to go into a further deep dive and to get further information. And so the first question that I want to ask you, Dr. Frazier, is what is amblyopia?
So amblyopia is defined typically as when the eye is healthy. So basically we don't see a specific issue with the eye necessarily, but the brain is deciding not to use that eye. And so a lot of lay people call it lazy eye. But in reality, it's not the eye itself is not lazy. It's just that there is a reason why the brain chooses not to use that eye, whether it is because of an eye turn or because that eye is blurry. So then the other eye becomes really strong and that eye gets a little forgotten. That's the way I'd like to tell parents. It's not that the eye is lazy, it's that the brain chooses to use the eye as the dominant, very dominant eye.
So they're using the stronger eye rather than the eye that has some type of weakness to it, whether, like you said, it's a turn or a blur. So it's more so not like you said that it's lazy, which is very interesting because I think growing up, you hear lazy eye and you assume, that the eye is just lazy, but you don't really understand why it's lazy. So it's very interesting to hear that it's so much deeper than just the eye being lazy, but that it goes all the way back to your brain and how your brain is choosing to use your eyes. So that's very interesting.
Exactly. Because and it's actually the brain trying to protect itself. Like, for example, if the child has an eye turn, then if they actually use both eyes, they would see double. So the brain chooses to turn that eye off and not use it so that the patient doesn't see double, so the child doesn't see double. So it's not that the eye is lazy in itself, it's that the brain is choosing to turn it off so that it doesn't have double vision.
Right. That's really cool. And so now that we know what amblyopia is, what are some common characteristics of amblyopia?
So this is really interesting. And we've had a lot of discussion with pediatric optometrists, pediatric ophthalmologists, pediatricians, because we used to think that most of the children who had amblyopia, it was due to an eye turn. But more and more we realized that a lot of these children don't necessarily have an eye turn, but they have a difference in prescription between the eyes. So one eye is blurry and they could be perfectly straight, but that eye that is blurry, whether it's because that eye is more far-sighted than the other or more nearsighted, that eye is more blurry than the other. So their eyes are perfectly straight, but the eye is blurry, so the brain decides to kind of turn it off. So a lot of the misperception is that people think, oh, a lazy eye, the child would have an eye turn, they would be obvious. But actually, the majority of amblyopia cases the children have straight eyes. So that's where the challenge comes from.
Wow, that's very interesting because I can imagine as someone that's a doctor, and maybe you're trained, the first thing that you're looking at is to see a difference in the size of the eye, not necessarily even thinking that it's not that is not always the telltale, that there could be something else that's wrong. And it's not, one eye being a little lazier or there being an eye turn, that there could actually be, normal size eyes and they're both straight, but that they still have amblyopia. So that's really interesting, and I think is something very important for our screeners to know, for parents to know, that you're not always looking for a difference in the way that the eye looks. It could be just how it functions.
Exactly. When I was telling you about when I was a child, nobody noticed that I had that because my eyes looked straight. But I had severe amblyopia. However, I had never been to any vision screenings, nothing. And so by the time they found out that I had amblyopia, I was already 12 or 13.
Wow.
So that's why it's super important to me. Now there's, of course, many years have passed, and thankfully there have been so many advances now to detect amblyopia early that the game has changed completely now.
Right. Well, that's a good thing. That's why we love technology, because it just, like you said, it advances and it makes it so that there is a little girl out there or a little boy that has amblyopia, but now they don't have to have the same story that you had, but they're able to know sooner and to just have a doctor that is aware of what amblyopia is and what to look for. So that is, I mean, truly the reason why we're doing this program. I'm sure the reason that you got into your career is so that we can make a difference and to spread this knowledge, because it's not common. And one of the things that I think that we talked about when we first spoke was that a lot of mothers don't get so much information on eye care when their baby is born, but they get so much information on everything else, so they don't know what to look for. And I think that that will lead us into kind of our next question is, so who does this affect? What population of people do we see with amblyopia? Is it common in adults? Is it more something that's common and found in children?
So about 5% of people in general have amblyopia. It used to be that because they weren't being detected early, so that was a really strong leading cause of vision loss, even in adults, because in unilateral usually. Like, let's say, for example, 50 years ago, a child did not get detected until they were in their 20s, and it turns out their right eye is 2200. At that age, it seems to be, well, there's been technology to treat them into the adult ages, but it's also very challenging. But that is actually one of the leading causes of unilateral vision loss in adults. However, we talk about children, that same 5% is affected. But since we're trying to detect them earlier, we end up treating them and curing them of their amblyopia. Because, for example, that same child that is 2 years old and is 2200 in one eye, we find them young, we put them in glasses, maybe we do the whole, and we're going to talk about all the types of treatment. By the time they're an adult, they are able to see well with each eye. So they are, in that sense, you would say they don't have amblyopia anymore because we treated it earlier. We found the risk factors, we treated them, and now the child no longer has amblyopia as when they grow up.
So it's better to, of course, get a child in there. It seems like it's easier to treat when they're younger and their brains are still developing. But once they're older and their brain is kind of already developed or they're slowing down in their development, it sounds like it's harder to, at that point, try to reverse it. If anything, it's more managing it than being able to reverse it.
Absolutely. So the difference is, if we find that child when they're young, then we, because the risk factors such as an eye turn or a difference in prescription, or some children who have a cataract, like a unilateral cataract, for example, if those things are treated early enough, then the risk of becoming amblyopic or continuing to have amblyopia is reduced, and you treat it and it's basically healed. they could still, for example, if that child who has a prescription that is really high in one eye and no prescription in the other eye, but you put them in glasses, yes, they will still need the glasses for the rest of their lives, but now both eyes will have the ability to see well, to be used together. They'll have good vision in each eye, good depth perception. So then you have treated the risk factors. And we used to think, we called the critical period of when you could treat amblyopia. We used to think that it was up until age 7. There is a lot of research now showing that, of course, brain plasticity happens until later in life. However, we're still, of course, the younger you treat, the easier it is to solve that issue. For example, if I have a child who is 6 months old and has a difference in the eyes, and I know that sounds terrible to think of a 6-month-old baby in glasses, but let's say that we go ahead and put them in glasses because they have very different prescriptions. That child will likely develop good vision in each eye and good depth perception and may have no issues. But if I don't find that child until they're 10, my odds of treating that vision are very, very low. Not impossible, but definitely very reduced.
Right. And so I hear that you're talking about risk factors. What are the risk factors of amblyopia?
And so the risk factors are, of course, eye turns. So yes, you could have amblyopia if you have an eye turn. And those are a little more obvious. They're detected a little younger, thankfully, because you could get really severe amblyopia from having an eye turn. The other big risk factor is the difference in prescription, which again, it's almost impossible to tell. I could be looking at a room of 10 children with straight eyes, and I would have no idea which one has that risk factors of difference in prescription unless there is a proper screening done where they measure the possibility of difference in prescription. And then the other big one that is also obvious is the opacities. For example, if they have a corneal opacity or a cataract or a lid that is lower, we call that ptosis. A lot of times, sometimes patients will tell me that that's a lazy eye, but it's called a ptosis, like a lid ptosis. Those are the risk factors. So it's mainly eye turns, difference in prescription, and then anything obstructing the view.
And so how do those risk factors affect vision? How, a person with 20/20 vision, obviously we see clearly, but how does someone with any of those risk factors, how does that change the way that they see, the way that they can navigate the world?
So the kids who have eye turns that are the obvious one, the brain immediately turns that eye off and ignores it. And hopefully we act quickly, we find them, and the child, if they need to have surgery, their eyes get strained. The children with the opacities or the lid ptosis, hopefully we act really soon and correct that issue so that they no longer have that obstruction in their vision. But then the kids who have those straight eye amblyopias, where the one eye is really blurry, usually they don't really have a lot of symptoms. You may have some of them because of their depth perception being reduced. They might be a little more clumsy. They may have a little bit more of a difficulty with peripheral vision and depth perception, of course, but they're not very obvious because let's say if I have a 2-year-old and their eyes are straight and their corneas are clear, no cataracts, no lid problems. And then the mom may say, well, they're a little clumsy, but some kids are clumsy. So,
Right.
but in reality, you may have a child who has 20/200 vision in one eye and 20 perfect in the other, and they can see everything. Like some of the patients, this is interesting that a lot of the patients, when I tell them, the parents would tell me, well, I'll tell them this eye is really blurry. And they'll tell me, well, but they can see like even little ants on the floor. I'm like, I
Wow.
realize that, but they're seeing them with one eye because children are not going to walk around and go like a little 2-year-old is not walking around and comparing. So we don't actually see a lot of symptoms of it. Maybe by the time they're school age, they may have some reading difficulties. Again, the peripheral vision issues, the clumsiness, but it's not very obvious. So that's where the
Right.
challenge is.
And that's interesting, like you said, because a lot of those characteristics, it sounds like just normal things that a
Mhm.
kid would do, tripping over their shoes or, missing something. So how would you really know unless you just took them in for a screening and was told that this is why they're a little bit more clumsy than the other kids. It's not just that they're clumsy. So I think that that's really interesting to know that that's a sign to look out for. You're thinking that your toddler is just clumsy, but it could actually be for a reason.
Exactly.
And so, we've identified the risk factors, we've identified how these risk factors can affect vision. And so, what are some treatment options? If you have diagnosed a child with amblyopia, what are some things that can be done to kind of try to reverse the effects?
So we are so glad when the patient like when they are in our office and we're doing the eye exam, we have so many things we can do. Of course, if there's an eye turn, a lot of times the child will need surgery. Sometimes some of the eye turns, there's, for example, one that is called accommodative esotropia, where the eyes are crossing from over focusing. So some of those are corrected with glasses. Once we get the child in glasses, their eyes are straight. But then the ones who have that difference in prescription, a lot of times, even if after we put them in glasses, we may need to do a time of where we call penalization of the good eye, where we may either patch or do a daily drop of this dilating agent called atropine, where we make the good eye blurry to force them to use the other eye. But the treatment usually includes glasses. So once we detect amblyopia, we typically will need to put them in glasses, and it may include surgery if there's an eye turn. And it usually includes either the drop or the patch to force them to use the other eye. And what we find is that the younger the child is, the sooner they respond to that treatment. And if they comply with the treatment, usually it depends on how bad the difference is between the eyes, but I usually tell parents that we may be in this process for about a year, depending on compliance and a lot of other factors. But the process takes a while. We end up usually seeing these little guys about every 2 to 3 months for a year and a half. And then eventually they end up just in glasses, or some of them we are able to put like in a contact lens in one eye, even if they're really young and they, for some reason, they don't want to wear glasses. So there's a lot of possibilities of what we can do, but we're very glad when they're in our office because we know we can do a lot about it. We can treat it.
Right. And that's such an amazing thing. And I know that that has to be so rewarding to
Yes.
know that, every month or every 2 months when they come in, you can see the improvement and know that your work is gratifying, that you're doing something that's going to change a little person's life for the rest of their life and just improve the quality of their life. So I know that that has to be an amazing experience to experience day in and day out. And I'm so jealous. I wish that I could be you and sit in your office and see that.
I love it.
And so, how can this be detected if you are a parent? And I know that we've talked over some of the characteristics, but if you are a parent, what are some things that you would tell a parent to look out for, in their young baby when they're bringing them home, just to see if this is something that could be a risk to them?
Yes, absolutely. So as a parent, it's super important with most babies when they're first born, there is usually an ophthalmologist who comes, and the pediatrician also. The pediatricians are majorly important because they look at the reflexes of both eyes to make sure that they're equal, that they can see through, that there's no opacities. So hopefully that was done at birth or within the first month of life. Pediatricians are key at detection of this major issues, because then the pediatrician could tell you if, for example, if there's a cataract, and immediately take action and refer you for surgery. But then the parents can also see if there's any kind of opacities, like looking into your kid's eyes. If you see any opacity, any crossing, any lid drooping, Now, for the one that is the difference in prescription, that has advanced a lot lately, and it's made a major difference because technology now, a lot of pediatricians' offices have little cameras that take a picture, and they can be at a really good distance from the baby, and they can measure, because the need for glasses is based on the eye measurements. So those little cameras measure the eye sizes actually, and they detect if there is a difference in eye size between the two eyes. So they're amazing. So a lot of pediatricians now have those. So a lot of babies are being detected early. And this has been a game changer just in like the last 10 years. Even my children who are 16 and 12 did not have that done when they were little. So they were not detected. If they had had a difference, they would not have been detected. But thankfully now the babies get detected as having a difference in eyesight. Now, as far as the parents seeing things at home, what they may see is, of course, the eye turns, the lid drooping, the opacities, the clumsiness. But that is why it's so important for the pediatricians to have early detection, and for the preschools. And a lot of our efforts now are trying to get those little cameras to the preschools to detect those children. Thankfully, and more, we used to do a lot of school age, so children would have kindergarten and second grade vision screenings with the cameras. But now we're trying to reach the Head Starts, the daycares, and like get in there sooner with those little cameras. And of course, the next step is if a parent receives one of those photos and it says that a child could potentially have one of those risk factors, then the parent needs to act immediately. And that's one of the big things we see there is the disparity as far as race and economical status, like any socioeconomic status, because the parents may have, the baby may have had a vision screening fail, but some populations have a harder time reaching access and getting to us sooner. So we're trying to get at those health barriers. For example, a lot of the Hispanic parents have the language barrier. A lot of the lower socioeconomic status parents have the transportation and getting off work. And so that there we find a little bit of a disparity of between getting from a failed screening to getting a full exam. Because the failed screening detects, oh yes, your child may have a difference between the eyes, but unless you go in and have the eye exam and get the glasses and start the treatment, then nothing is being done. So there is a gap there.
And I'm so glad that you brought that up, because that is something that we're always discussing, is that the failed screening is not the last step. That's not where you stop. You then have to go and you have to be referred and have that full comprehensive eye exam to really know what's going on, because a kid can fail a screening, but a screener cannot diagnose. So they can't really tell you what's going on. They can only tell you what a machine may be picking up on. So like Dr. Frazier said, it's so important that you take that next step to take your child to see an optometrist or an ophthalmologist once you've received that failed screening, just so that you can make sure that you're setting your child up and getting them the treatment that's necessary. But also, I am so glad that you guys are doing all that you're doing for those underserved communities to try to get treatment to them, because as you said, that is such, when we're speaking about making sure that children have treatment, those are the two issues: making sure that the parent, of course, knows that the treatment is required, but also those parents that know, but they just don't have the means. They don't have a way to make it happen. And so it's so awesome to hear that you are, getting these little cameras to these Head Start programs and to daycare, so that, we can detect early, and also doing all that you can to make sure that children and populations that really need this care, that they're getting it. So thank you for all that you're doing in your community. And I know that that's so important, and it's definitely making a difference in some child's life as we speak.
Yes, and pediatricians are, I mean, they are amazing because they're trying to, I mean, they're taking care of a whole body.
Right.
And we get a lot of referrals from pediatricians who, whether they have access to the cameras or not, they're still really good at, they do something with their ophthalmoscope that is called looking at the red reflex to make sure that it's equal, and that gives them a lot of information too. So the pediatricians, whenever a parent gets a recommendation from the pediatrician that to get an eye exam, they should follow that, because that pediatrician, if they have found a risk factor for amblyopia, again, that child needs to get their eye exam as soon as possible.
Exactly. And so the last question that I have is amblyopia. Is this something that is genetic? Can it be passed on from a mother or a father to a child? Is this something that just anyone, even if your parents don't have this, you can still have it? How does amblyopia work? Do we know?
So yes, there are genetic factors. So there are families who tend to have strabismus. Then there's families who tend to have high refractive errors or like the need for glasses. So I would say that if there is a family history of any eye problems, then yes, I would say your child probably needs I would say a full exam, even if they pass the screening at school or the pediatrician. I would say I would recommend, like my children, I made sure they had full eye exams because
Right.
they have risk factors just because they're my kids.
Right.
Because eye size and eye shape is genetic. For example, a lot of Hispanic children have astigmatism, which is from the cornea being a little more oval. So a lot of those kids, we can pretty much tell you, like if they look Hispanic, they're going to have risk factor for amblyopia. Of course, the cataracts and a lot of the big risk factors like the corneal opacities and cataracts and things like that can be genetic. And I don't, like, I usually tell the parents, like, I don't want to put a guilt on you. I just want you to use it more as, okay, so if I have eye problems, I should have my child checked to make sure that they don't, because there is a genetic component to it. However, there are a lot of times, for example, in my particular situation, my mom did not have eye problems. My dad did not have eye problems, but somehow a recessive gene in there gave me eye problems. So it doesn't mean that you can't have it if you don't have if you don't have genetics for it. So it still can happen, absolutely. And the key to it, because I know there's a lot of guilt with that involved too. I always tell them, like, it's not that you gave it to your child. The main thing is to be aware, like, okay, if I have eye problems, then I should have my kid checked to rule them out. And if they don't, that's great. But if they
Right.
do, we can do early intervention in those eye problems and go ahead and take care of them. Like, and the key, with amblyopia, the key is getting there the sooner the better, because if we can get those kids to get in their glasses, correct whatever prescription they need and do the treatment, then the process is pretty smooth. If you start really early, it becomes a little, I think, challenging. One of the big challenges that we have with amblyopia treatment is once they get older, there's just not enough hours in the day. For example, if you need to patch a 10-year-old who is in school and is at baseball practice and has all these other things going on, it is a lot more challenging to find the time for it, versus if you detect an amblyopia risk factor in a 1-year-old and you go ahead and take care of all the patching or whatever you're going to need to do at that age, that is a lot easier than finding the time. And because a lot of kids, of course, don't want to wear a patch to school.
Right.
They don't want you to put a drop in their eye because it makes their eye blurry and it could affect their school performance. So
Right.
there's a lot of other things that get in the way of treatment the older the kid gets.
And so the last question, I know I said the last question was the last, but this is truly the last question is what advice would you have for any parent at all maybe a parent of a child with amblyopia or a parent that's soon to be, that's expecting, what advice can you give them just to prepare themselves and to set their child up for the best future that they can have? What would you tell them?
I would say that as a parent, it's important to advocate for your child and make sure that at the pediatrician that you're visiting is doing some kind of vision screening, whether it is through a machine or through the ophthalmoscope. If that is not being done at the pediatrician, so I would say that during those well-child checkups, that you make sure that there is something being checked with your child's eyes. If that's not being done, then ask the pediatrician if they could refer you to an eye doctor. Also, making sure that if the child fails a vision screening, that you reach for further eye care, because there's really a lot of some parents may tell me, for example, oh, we didn't have vision insurance. Well, it turns out that if you have an amblyopia risk factor, then your health insurance will cover it, will cover the eye exam in most instances. For example, if the pediatrician suspects that if they did a screening and they suspect that the child may have amblyopia, then they'll refer them to us. We'll do a full exam and use the health insurance for it, because that is a health issue. It's not, you're not reaching out just to see if your child needs glasses. You're reaching out to make sure that your child doesn't have amblyopia, which is a health concern. So that is one big thing, is to make sure that if the child fails the screening, that is not the end point. The end point is go get your full exam, and then as soon as possible, because time is of essence here with amblyopia treatment, and that you comply with the further care. Now, a full exam must include dilation. So be prepared for that. Yes, it is a little I know a lot of parents are hesitant, like they're 6-month-old getting drops and all that, but actually it's not. Usually that those are the easiest eye exams. The 6-month-olds, for example, they don't have not developed the corneal sensitivity, so the drops don't really bother them. They're not worried about the blurry vision, so the earlier, the easier. And a full exam does include a dilated eye exam, so they will have to have eye drops. So it's basically following the process. If you fail the screening, make sure that your child does get a vision screening. If the child fails the vision screening, make sure that your child gets a full exam, and then that you comply with treatment if necessary, glasses or patches or whatever needs to be done. The sooner, the better.
And with that being said, I want to just bring up here again that the infancy program, which is such an amazing program, is available to parents that want a comprehensive eye exam for their baby. So you can go and you can find a provider near you that is an infancy provider that will provide that free comprehensive eye exam with dilation to your baby. I believe that it starts at 6 months of age. So as long as your baby is 6 months old, you can register to find if you can find a provider in your area and go ahead and get them scheduled and get that first exam done, get it out the way. Because it's so important, and make it a habit. Don't just let the one eye exam be the only eye exam that you attend. Go regularly. Go as soon as you're scheduling their doctor's appointments. If they're going yearly, schedule that eye exam yearly as well, just so that as your baby's growing, you can make sure that their eyes are growing as they should be as well, and that you're catching everything that you should catch. And so, Dr. Frazier, it was such a pleasure to have you here today. And you've dropped so much amazing knowledge on myself, and I'm sure our listeners. So we definitely do appreciate having you. And thank you guys for listening to our podcast. Again, this is the APV Podcast, and tune in for the next episode.
Thank you. It was my pleasure.
Thank you. Bye-bye.